So the title of my presentation is The Behavior of the NIRS-derived Oxygen Extraction Signal at the Limit of Exercise Tolerance. We are, in my lab, interested in this device as it can give us some insight into the behavior of oxygen during exercise. And in my lab, we are interested in the metabolic responses to mainly cycling exercise. And the measurements that we usually perform are related to oxygen uptake, blood lactate concentration, and oxygen extraction. And particularly for oxygen extraction, we assess this variable during different types of exercise. However, all these measurements are related to themselves. For example, the oxygen extraction is strictly related to the oxygen uptake, the VO2, because of the Fick equation that tells that VO2 equals blood flow time oxygen extraction. So everything is related. But what is oxygen extraction? So let's consider our vascular system. At sea level, usually we have 20 milliliters of oxygen every 100 mils of blood. And basically oxygen extraction is nothing else than the difference between the arterial content of oxygen and the venous content of oxygen. And at rest, we usually extract 5 milliliters of oxygen, whereas during maximal exercise, we can get up to 15 or 16 milliliters of oxygen. And as we see from this graph, the extraction is mainly related to the dynamic balance between muscle blood flow and muscle VO2, so oxygen provision and oxygen utilization. How do we measure it? We can measure it invasively through catheters, as we see here in this picture. So there are catheters inserted in the venous, in the veins and in the arteries. So in this way we can calculate the difference between the content of oxygen, and usually the profile of the oxygen extraction is a linear or a hyperbolic increase during a ramp incremental test. However, this methodology is pretty invasive, and not every lab can perform this type of measurements. Also, if we consider that if we consider the use of catheters, we know that it represents only a whole limb measure. It's a whole limb measurement, so we don't know the contribution of each of the separate muscles to the overall measurement. And as I said before, we have this balance between muscle blood flow and muscle VO2, which means that each region of the muscle may have a different balance, which is related to the fiber type expression, as well as the vascular controls, as well as the muscle activity. So there could be an heterogeneity in the balance between these two factors. To avoid, or in part, try to limit these limitations, we can use the near-infrared spectroscopy, which is a device that allows us to measure locally the deoxyhemoglobin, which is one of the signals that can give us an idea of oxygen extraction. So this deoxyhemoglobin signal is also called HHB. So from now on, I will refer to this signal as HHB. How does it work? Behind the NIRS, but basically we have a source of light, infrared light. This light travels through the tissue, hopefully to the muscle, and the detector will detect this light. And based on the level of absorption, we have an idea of oxygen extraction. And the light penetration within the NIRS that we are using in our lab is 3 centimeters, so we can get as deep as 3 centimeters. As I said, I'm interested in this variable during two modalities of exercise: ramp incremental and constant load. I'm sure that all of you are familiar with this type of exercise, but basically ramp incremental test is
an exercise test during which resistance is increased very smoothly, so 1 watt every 2 or 3 or 4 seconds, depending on the slope that we decide to have. And the constant load exercise is just basically a constant wave transition from a lower to a higher work rate. It is important to say, however, that the behavior of the HHB has been already described in the literature during ramp incremental test. Usually we have a linear increase followed by a plateau. And the point at which this plateau begins to occur has been defined as HHB breakpoint. And it has also been associated to other indices of aerobic fitness or variables of metabolic homeostasis, such as the respiratory compensation point, which is the hyperventilatory response during ramp incremental exercise, critical power, and maximal lactate steady state. All these markers are demonstrated to occur at a similar metabolic rate, so at a similar VO2, as we see in this table. So with this, I want to say, I want to point out that there might be like a common physiological happening here, above which, common metabolic rate, above which there is a progressive loss in metabolic stability, as we see, for example, here with accumulation of lactate. However, the problem with the HHB breakpoint is that it's a relatively new index, and we didn't know if that was just by chance, or it was this occurrence, or it was like a consistent finding. So the first step that we undertook in my research was to see if this breakpoint was a repeatable measure. And we simply did 2 testing sessions. So participants would come in our lab and would be tested for during the ramp incremental test. And what we found was that the HHB has, again, showed this linear increase and a plateau towards the end, and the breakpoint occurred at 80% of the peak power output. And in test 2, pretty much the same, linear increase and plateau towards the end, and same percentage of peak power output. And when we look at the metabolic rate, again, very, very similar, 3.5 liters per minute if we plot the HHB against the VO2, and it was very associated also to the respiratory compensation point. So the conclusion of this first study was that this index is repeatable and can be associated to other more established measurement of aerobic fitness. But then, as I said before, I was also interested to see how this behavior was going to change between different muscles. If, for example, vastus medialis was showing the same, and as well as the rectus femoris. So we asked participants to come back and to perform again another ramp incremental test. And we saw that, again, linear increase, plateau. We saw that the vastus medialis is pretty much the same, has the same behavior, the breakpoint occurring at 80% of the peak power output. However, when we look at the rectus femoris HHB, so oxygen extraction, we see an attenuated increase in the HHB in the first portion of the test, followed by a steeper increase towards the end. But interestingly, by fitting a double linear model, we saw that there is actually also here a breakpoint in the signal, signifying that in different muscles there might be changes in the environment, which leads to alteration of the blood delivery and blood utilization. When we look at the activation of these muscles during the ramp incremental test, we see that the vastus lateralis and the vastus medialis are pretty similar, so in the profile, whereas the rectus femoris is attenuated in the first portion of the test, and it shows a steeper increase towards the end. So it seems that the lower increase in the HHB is associated with a lower activation, which makes sense because lower metabolic activity, lower reliance on oxygen extraction. But as we see here, we have an increase in the mg that is not reflected at all in the HHB. So there is this plateau in both these muscles that is kind of counterintuitive. Like if we have a greater metabolic activity, I would assume that there is a greater reliance on oxygen extraction because VO2 supposedly is going up in those muscles, but it's not. We'll get there. I'll try to explain why this is happening, hopefully. And the conclusion of this second study was that, yeah, there could be a relationship between HHB and muscle activation, even though at higher exercise intensities may not be completely true. And there is an heterogeneity in the profiles between the rectus femoris, the vastus lateralis, and the vastus medialis, but not in the occurrence of these breakpoints in the signal. And then if we want to translate these findings into constant load exercise, I said before that this index, this HHB breakpoint was associated to this maximal lactate steady state. MLSS is the highest intensity of exercise at which we can exercise, maintaining metabolic stability. So lactate is not accumulating, is elevated but not being accumulated in the blood. So if that breakpoint occurs at the same metabolic rate of this index, then I would assume that above this metabolic rate, the HHB of the vastus lateralis will not increase. And this was the hypothesis of the third study. So participants came in, they performed two sessions at MLSS at this intensity, and also 10 watts above, so slightly above, very little increase. However, after each of the exercise bouts, these were 30 minutes long, they were asked to perform a time to exhaustion. So 3 minutes of recovery and a time to exhaustion immediately after at 80% of the peak power output, which elicited a time to exhaustion of 4 or 5 minutes. So they were at VO2 max, so they stopped cycling because they were no longer able to sustain that power. And these are the findings. So here we have in white or the HHB and the EMG activity at MLSS and 10 watts above. And these dots here represent the time to exhaustions. And here we have the 30 minutes rides. So when we are cycling at MLSS and above MLSS, HHB is stable and does not increase even during the time to exhaustion. In both cases, even when we are cycling at MLSS, we did not find any statistical significance between the 10-minute mark and the 30th, not even when they were cycling at exhaustion. So it's very surprising. So in the VL muscle, we are not relying anymore on oxygen extraction. It seems that we could even say that VO2 is not increasing in that specific muscle, despite the increase in the EMG activity. So here MLSS, a little bit attenuated, even though we found a significant difference between the 10th and the 30th minute, but then a greater increase during the time to exhaustion, which makes sense because we are exercising to exhaustion. Now, when we plot the rectus femoris, HHB, and EMG, we clearly see that there is an increase in the HHB in the rectus femoris, in both exercise conditions, which was 14% and 8% approximately. So rectus femoris is still relying on oxygen extraction. And it's kind of matched with the EMG activity of this muscle. So the conclusion of this study was, one of the conclusions of this study was that the plateau seems independent, the plateau in the VL muscle, in the oxygen extraction, seems independent of the exercise protocol adopted. Rather, it seems associated to a kind of maximal metabolic rate. And now you might wondering now, what's the implication of all this? Okay, there are differences in muscles in terms of oxygen extraction, in terms of, it's better to say, in terms of oxygen delivery and utilization, but what's the implication of this? My idea is that there might be, there could be a sort of mechanisms that in some muscle, there is a sort of limitation in oxygen extraction that in some that leads some muscle to contribute more than others in the loss of metabolic stability. If we look, for example, at the physiological responses during the 30 minutes bout, we see that VO2 is stable at MLSS and above MLSS, but ventilation is going much higher when we are riding 10 watts above, as well as lactate. So this tells us that something is going wrong. We are losing that metabolic stability. Also, RPE is going up. And these are only 10 watts difference. If I put some of you on the bike and I ask you to cycle 100 watts or 110 watts, probably nobody will be able to detect the difference at the beginning. So it's a very, very light, a very, very small difference. And these are the physiological consequences. Now, keep in mind the protocol that we designed. We also asked them to do a time to exhaustion without exercise, any prior exercise. So kind of baseline time to exhaustion. Oh, I forgot that. Baseline time to exhaustion. So this is the optimal condition, no prior exercise. And this was the time that they achieved. So now when they performed the condition at MLSS, the performance decreased by almost 50%, which makes sense. They were fatigued from the previous bout. But now when they exercised only 10 watts above for 30 minutes, fatigue was, the decrease in time to exhaustion was completely disproportionate to the increase in work that between the two conditions. So this ability to regulate delivery and utilization of of oxygen within different muscles can have an impact on our ability to sustain exercise for a prolonged period of time, and also in terms of performance. So now, if we go back to the Fick equation, and if we have this in mind, we can better understand the behavior, especially in the vastus lateralis, the behavior of the oxygen extraction, especially in the vastus lateralis. So we said there is a plateau that corresponds to a specific metabolic rate. So if we say that there is this plateau, and we also assume that there is an increase in VO2, which we could imply given the increase in the EMG, and given the fact that when we are exercising to exhaustion, VO2 is still increasing because we are going to VO2 max, then according to the Fick equation, blood flow should be higher. However, we can also have another condition where oxygen extraction plateaus, VO2 also does not increase, and blood flow is stable. And related to this Fick equation, we might have three hypotheses mainly, and three hypotheses have been formulated based on this, explaining why we have this leveling off in the HHB. The first one revolves around the notion that, okay, we have an increase in blood flow due to the metabolites accumulation, local accumulation of hydrogen ions, lactate, and so on, which would trigger like a vasodilatory response, which attenuates the need to extract oxygen. On the other side, we can have diffusive limitation between the capillaries and the muscles, with this setting a sort of upper limit in oxygen extraction. So we cannot anymore extract oxygen above this metabolic rate, according to this hypothesis. And third hypothesis is that we achieve a plateau in the VO2. VO2 cannot increase anymore due to shifts in muscle activation. So above a certain metabolic rate, we are recruiting more muscles, such as gluteus or the rectus femoris itself, or we are recruiting different fiber types, so not anymore only type 1 fibers, but also type 2 fibers, which would use less oxygen, according to this. So we said, okay, let's try to test one of these hypotheses. And the easiest one to test was, okay, let's see if there is a diffusive limitation, So if this plateau actually represents an upper limit in oxygen extraction. So what we did was answering this question. So does the plateau in the HHB signal represent the upper limit in oxygen extraction during ramp exercise? And what we did was, again, a simple ramp incremental test. But this time, at the end, participants were not allowed to rest. We said, okay, immediately after, we are going to occlude your leg for 2 minutes. So this is VO2 max. So people are exhausted. They cannot go anymore. They are dead. And we occluded the leg. And this was our setup. So the cuff just here, blue, on the upper thigh, and the NIRS covered by the bandage. And what we got was, again, a linear, these are raw data. Linear increase, almost linear, plateau with a breakpoint. So now, if at occlusion we see a steady state response, then okay, there is a diffusive limitation. But if we see an overshoot, then there is no diffusion. And that's what we found. We found that there is a reserve in oxygen extraction. Probably reserve is not the right term, but we couldn't come up with a better word. So there is actually an overshoot. And this increase in oxygen extraction here represents VO2, because we are occluding, now we don't have blood flow, and according to the Fick equation, we are only relying on oxygen extraction. And this reserve was about 30% in all the participants. Despite these findings, and despite the paper was accepted, luckily, one of the reviewers pointed out that, okay, but how do you know if this is something that is not induced by the cuff? So the cuff is going to be inflated at 300 millimeters of mercury, so the highest that we could do. So there could be some redistribution of blood in the quadriceps that would kind of trigger like more deoxygenated hemoglobin towards the superficial muscle. So he said, good findings, but you should also demonstrate that this is something intrinsic to other muscles and also to other like layers of muscle. So I had the opportunity to go to Japan for the following up study. So yeah, this is the conclusion. And because in Japan they had the opportunity to, I had the opportunity to use this NIRS, which is slightly more powerful than the one that we have in Calgary. And if you remember the previous slides, so we have an emitter and a detector, and the NIRS that we are using in our lab goes as deep as 3 centimeters. But with this type of NIRS, we were able to get down to 6 centimeters, so slightly deeper, to see if actually there was a redistribution of blood towards the superficial muscle. So again, we repeated our protocol, ramp incremental test, occlusion, approximately 2 minutes of occlusion, and we investigated superficial vastus lateralis, superficial rectus femoris, so with the same resolution as we have here in Calgary, but also deep muscle, so 6 centimeters deeper. 3. So in terms of profiling, we found pretty much the same, which was what we were expecting. So this is vastus lateralis superficial, deep, and rectus femoris. So again, increase, plateau, also in the deep muscle, increase, plateau, but not in the rectus femoris. But now when we look at the reserve, we found that the reserve, which is this dark gray here, is present in all the muscle, and also in the deep portion especially. So it's something that is intrinsic. So these are the peak values at exercise exhaustion. But interesting to see is that we found a greater overshoot in the deep portion of the muscle, significantly greater, which is kind of nice, because this finding very well fits with the common notion that deep muscle has a greater proportion of type 1 fibers, which lead to the fact that we have a greater blood flow in deep versus superficial muscle. This is an MRI study, and this is the quadriceps at rest and during exercise. And as we see from the darker areas, blood flow is greater in deeper tissue. So it's nice to have like to have support from previous research, and even more invasive. These are studies on cadavers, so it's good to have this. But the other interesting thing is that the exercise modality here is submaximal. So it's a leg extension exercise. So we are able actually to expand these findings also at much higher exercise intensities. So now to summarize all these findings, we have this index, the HHB breakpoint in the vastus lateralis muscle, that can be considered like a reliable and repeatable index of exercise fitness. The plateau, however, seems independent of the exercise mode employed, ramp versus constant load, and it seems to happen at a specific metabolic rate, which is actually the highest metabolic rate at which we can keep metabolic stability. However, this plateau does not seem to be representing the upper limit in oxygen extraction, given the overshoot in the signal during the occlusion. However, about the mechanisms, we can exclude the first one of the hypotheses that I made, but we still don't know if there is an increase in blood flow or if there is a level off in VO2. I would say, given the increase in EMG activity and given the fact that VO2 is still going up towards VO2 max, maybe we have a local redistribution of blood in the vastus lateralis, but as long as we cannot measure capillary blood flow, because technology still does not allow us to do so reliably, we still can answer this question. So I don't know. Do not ask me for the mechanisms controlling this plateau. Yeah, thank you. I want to acknowledge my supervisor, important people in my lab who contributed helping me, Dr. Koga and Dr. Okushima at Kobe University, and more than 100 participants in my studies. Sorry for all the pain. Maybe someone is here. And yeah, thank you.
Great. Any questions for Danilo?
Yep.
Next talk. I'm curious with the y-axis that you use. It seemed that there was a 100% increase in the HHB. Does that represent that twice as much oxygen being extracted from the blood compared to a rested state, or what do those numbers represent?
So here?
Yes.
Okay, so these are normalized data. So from 0 to 100, so 0 is baseline, 100 is peak. So this was done to see if there were, to normalize between the profiles, between each, among the muscles. However, we did normalize also for baseline. So I'm not showing the graph, so there was no 100%. It was just 0 was baseline and whatever was above was the activation. And actually, we did not find differences in activation between these muscles at peak exercise. However, we know the limitation associated with the EMG, especially when we are normalizing against baseline. So yeah, this is 0 to 100%.
What does 100% mean?
Peak exercise, peak activation.
So it's always going to be 100%?
Yeah, yeah. In this case, yeah. Yeah. Yeah.
Okay. So it seems that it could be mediated by how quickly the blood is flowing through the muscle.
Mm.
And the time in transit could be limiting how much oxygen can be extracted, and that would represent the, or what you call the reserve, that the blood is pooled there so more oxygen can be removed. What if you tried compressing the muscle so that the total rate of blood flow is reduced? Do you think you'd see a similar reserve?
Okay, so there is also another hypothesis saying that this plateau is due to short capillary transit time at VO2 towards VO2 max. So we have to think that we have a lot of pressure, a lot of blood going to the legs, and the transit time, so the time that is needed for oxygen to diffuse from the capillaries to the muscles, is reducing more and more at higher exercise intensity. So this was one of the explanations of this plateau, but I don't think if we allow for more capillary transit time, we won't see this plateau and we would see a higher overshoot. I don't think so, because it was also demonstrated that, for example, capillary transit time is not a limiting factor even for people having 80 mils per kilograms of VO2 max, so really like top athletes. So I don't think changing the capillary transit time will make a difference. Yeah.
So just a curiosity, what's the delay of the patient to a square wave exercise for NIRS measurements?
The delay of, sorry?
Like if you apply a square wave exercise, let's assume at
Here.
50, yeah, exactly.
Yeah.
What the time delay of this?
So you mean to achieve steady state?
Yeah.
So I would say that I see steady state response after 5-6 minutes. It's already like at almost steady state. But I think it also depends on the way we activate the muscle. So we have a very small picture here. It's the vastus lateralis, but we have also other muscles. So there might be someone achieving steady state earlier on time, someone delay it just because the recruitment pattern is different between people. So it's very dependent on that as well. It's not just dependent on how quickly we send blood.
And can these measurements affect the measurement that you measure during a ramp test, like the delay? Like you assume that the steady state is at 80% of peak power output.
Mm-hmm.
Maybe there is a delay, so maybe it's 75. No.
What do you mean with a delay? I'm not understanding.
The adaptation.
Well, we usually see, if you see so if you see here in VL and VM, there is always a little bit of undershoot at the beginning of the ramp, but that is related to like sort of hyperemic response when the load is increased. So you always have to consider that the muscle is a pump. So as soon as you change workload, this pump effect will trigger a little bit more blood, which makes the HHB going down. Because more blood you have, lower reliance on oxygen extraction. But I don't think this is going to affect that.
I'm curious about the lack of RF activation.
Here.
Yeah, and
Yeah.
I'm thinking about the mechanics of RF activation during cycling and its role as a two-joint
Yeah.
muscle. So do you think that it might be activated later because you need to activate other muscles to help stabilize the joints, or maybe it's just not at an advantageous angle for your activity? Maybe that's why you're seeing the results there.
Yeah, for sure. This is a biomechanical consequence of, this is a biarticular muscle, and these are monoarticular. So there is for sure, as I said, there is a relationship because we see higher activation, higher HHB, lower activation, lower HHB. So it's related to the metabolic activity, and the fact that we are, during a ramp test, we are activating rectus femoris, like the rectus femoris activation is attenuated is because of that. So mainly what the rectus femoris does, I know that probably you all know that, is just the pulling action, so the recovery phase plus kind of the forward force at the beginning of the stroke. So let's say at lower intensities, we don't need such an exacerbated pulling action. But then when we are getting closer to max, we need that action to support the primer movers, which are medialis and lateralis.
And then to follow that up, if you were to do an activity that more preferentially activates RF, do you think you'd see the same results in RF as you do in VL and VM?
So that's our next step. So now we got a system that allows us to do single leg cycling in a more ecological way, so we can put weights on the other side. So what we are trying to see if, okay, let's activate more rectus femoris. Probably what I was trying to say is that there is this critical intensity, so this critical metabolic rate that it's not just systemic. It can be tackled muscle by muscle, in my opinion, and that the fact is that probably we don't get to that in the rectus femoris because we achieve exhaustion before the rectus femoris is completely tired, during cycling, of course. So maybe if we do a leg cycling, single leg cycling exercise, and we will be able to activate rectus femoris at a higher percentage, like a greater proportion, then we might probably see a plateau here in the HHB. But I don't know yet.
Right on question. Just quick, Danilo, can you describe the processing of the EMG signal?
Okay. Okay, so what we did was normalization against baseline. So we also did the MVC before. I normalized also against the MVC, so extension, leg extension, but I'm not sure that there is an appropriate way to do it for cycling, when we are normalizing for cycling, especially if you want to see changes in patterns. I found that normalizing against baseline is more appropriate, and this is just the root mean square, like average of the root mean square.
Yeah. I may have one suggestion. It looks like near the end, where you have like the dissociation between the two pairs.
Yeah.
There's a technique you can do of whitening the EMG signal, and I wonder if that might better match the HHB curve with EMG than that.
Okay, I have no idea about.
Yeah.
Maybe I'll stop by to your.
Yeah, sounds good.
Danilo, have you seen any data looking at changes in inspired oxygen pressures on the NIRS signal?
You mean hypoxia?
Hypoxia or
hypoxia? Yeah, there are studies, and there is only one study actually. One study is showing that this plateau with hypoxia comes earlier on time.
And there's still a plateau.
And there is still a plateau. Yeah, we were thinking to do also an hypoxic intervention, but by doing hypoxia, what happens is that you lower the partial pressure of oxygen, like arterial partial pressure of oxygen, so you kind of upregulate everything. So if we want to kind of, it's not a super ecological situation. Yeah.
Some people consider that the total hemoglobin can represent muscle blood flow.
No.
You don't believe?
No. So among other signals, so we have the oxyhemoglobin, tissue saturation, and total hemoglobin signal that we can get from the NIRS. Total hemoglobin is not blood flow. Total hemoglobin is it's blood volume. They refer to that as a blood volume. So it's like how much volume of blood you have, which is different than blood flow. So it's like capillary recruitment. So hematocrit or something like that. But I'm not very familiar with total hemoglobin. But we did monitor also total hemoglobin, because in any situation, if you have lower total hemoglobin or higher total hemoglobin, that HHB is going to be different. But in all our studies, it was constant, even during the occlusions. So.
You ever thought of like isolating a specific muscle and then seeing what the maximum O2 consumption of that muscle is during pre-exercise, and then compare it to see if, say, your percent increase and where you get that plateau, if that actually matches up with where you're seeing the plateau?
Yeah, how do you measure VO2 of the muscle?
I don't know, but like say like with your rectus femoris,
yeah,
you know that you're not actually hitting the plateau there.
Yeah, absolutely.
So, with the VM, do you think that if you actually did an exercise that isolated that muscle more specifically and fatigued it, do you think that you'd still get the same plateau?
So, so you say you do exercise before, or?
So you did the same protocol that you're doing now.
Yeah.
But instead of doing a cycling exercise, you did something that specifically isolated the VL. Do you think that you could exceed that plateau?
So in Japan, where I was, they were doing leg extension exercise. And according to the researcher, they are still finding a plateau in the vastus lateralis, even if leg extension is just, I mean.
But is it at the same point?
I don't know that. I'm not sure. Yeah.
And I suppose to keep it is whether the plateau goes below the reserve.
Yeah. I would say that if you're doing leg extension, single leg extension, you don't have. Because what we are completely kind of ignoring is the central component now. But this also can be another limiting factor. But I would say that if you do a single leg extension, there is no cardiac limit, no central limitation. So it might be, theoretically, we shouldn't be seeing this plateau because there is enough blood. But they told me that they saw it, so I'm waiting for the paper.
Brian?
So did you say when you did the exercise after MLSS it was at 80%?
Yeah.
80% again of what?
Peak power output, sorry.
And that's the same power output as MLSS?
No.
I thought you said it was at 80% too. All your
So MLSS, we did 30 watts ramp. So MLSS is usually 60% of the peak power output, whereas the time to exhaustion is 80% of the peak power output.
Okay, but when you were talking about all of your measures being the same, the respiratory compensation point and whatever else you had in there, I thought you said they were at 80%.
Yeah. Here. So you mean this? If I go back. Yeah. So yeah, but there is what we have to think about is that there is a dissociation between the power output during the ramp incremental test and the power output during constant load exercise. So in this case, yeah, they were matching, but in the following.
These are matching, but you also had a slide that showed respiratory compensation point.
Yeah, from Kier's paper. Here.
Oh, so that's somebody else's paper?
Yeah, it's not my paper.
Oh, okay.
Yeah.
But here, so this was critical power, maximal lactate, steady state,
Yeah.
respiratory compensation point, all at 80%. So that's why I was wondering, well, why was your
80% of what? VO2 max or peak power output?
well, okay.
So there are differences in power output, just because there is this dissociation between ramp exercise and constant load exercise. So we cannot derive a power output from the ramp exercise and just exercise at that power output to elicit the same metabolic response.
So when you say they're all the same, it's the same
Metabolic rate, not power output. Yeah, power output can be anything. I mean, anything. We know the limitations of the power output.
So you're talking about the peak power output that was achieved during the ramping?
Yeah.
Okay.
Yeah.
How did you decide where the inflection point was? In the slide you were just on, it looks like it goes up to 90%, but then you say that the point is at 80%. So
Yeah. Okay, so that's a good point. But so these are the average from each participant. So when you fit the double linear model, you get a value. But when you average the profiles, so this is 0, 100%, someone might be 77, someone might be 83, 81. So when you average them together, the curve, it's not even anymore like a double linear, it's more like an attenuation of the curve. So yeah, this is the effect of the data processing. But the actual average coming from each individual fit was that.
Okay, so it's from a double linear model. And then the one on the other slides, that was a single person's data.
Oh, yeah.
Okay.
Well, that is also, I mean, we feed the data with a double linear model. Yeah.
So another question then. A lot of times in biomechanics and motor control, people have this idea of the vastus, the Alice having compartmentalization, and you can control them potentially independently. Can the NIRS system have the resolution to potentially pick up those compartments, or what kind of range are you working with the NIRS
Well,
system?
the resolution is, as I said, like it goes as deep as 3 centimeters, and like the area of investigation is like a couple of centimeters square, so it's very, very small. This is again a little picture of the whole thing. So we are assuming that even in the vastus lateralis, everything is as I'm showing, but there might be differences between distal and the distal portion and the proximal portion. So yeah.
Any other questions for Danilo? All right, let's thank you for his presentation.
Thank you.
All right, next week we will have Dr. Amin Kameli present his research on local mechanical behavior of cartilage. See you next week.